Okay, that already have discussed. Sometimes, like initially, unless anatomical correlation is available to denote normal structure, pathological site of FDG accumulation can easily be controlled. That was the lacuna with PET. So that lacuna was overcome by PET CT fusion. Because is that we can easily know the way, through anatomical site where this normal signal is coming from, whether it's the normal physiological or normal. So that way we can reduce the false positive and false negative finding. I already told about the overall, it will improve the sensitivity and specificity by using a PET CT scanner. So this is a very old PET CT scanner. So in PET CT, most of company they used to put a front side. This is a table side. The front side is CT and back side is PET. This configuration, all company are doing the same way. Because why? Because first we used to perform a CT, all body CT. For CT Scott images we used to take. So on Scott images and after Scott images CT we used to perform, and then subsequently on the basis of a Scott images bed divided by for PET acquisition. And see here, that clearly mentioned that the distance between CT gantry to PET gantry is, let us say, in this 80 centimeter. So what we'll do, this is two standalone modality. इसमें कोई बातचीत नहीं होती है कि हम तुम्हारे साथ हैं, तुम हमारे साथ हो. Once the signal is generated, it leads to one registry center, the software-based integration, where this both information, like if you assume here is the first centimeter and here is the 81 centimeter. So images coming from first centimeter and 31 centimeter location is automatically overlay each other. So that way, on the basis of software, but here we are ensuring that patient acquisition we have done simultaneously. So that giving confidence that okay, no problem. This is the proper fusion. But on the basis of software, here we are also fusing the image on overlaying the physiological image on the CT image. See, this way we used to perform for first bed 1, bed 2 sequential 1 by 1. That much field of view 16.5 kV we used to perform in one time, then slightly patient bed move, second, third, fourth, like that. But apart from so much development, there is a certain limitation, and that limitation and a certain artifact we used to present. First is patient motion. That we have to be reduced. And for that we have to do a patient and their attendant counseling before the PET-CT scan to gather a maximum cooperation from the patient to reduce the patient motion. Okay? And second, that can generate system-based correction artifact might be generated sometime because of some metal also generated. Sometimes truncation artifact is caused. So these are other contrast enhanced related challenges. Pacemaker, dental devices. So these are all reasons for generation of artifacts. But advantage is much more. That I have already discussed. Again, the same excellent functional information, superb spatial resolution of CT, attenuation correction for quantitative, semi-quantitative because of CT. We all know how nicely we can correct CT data, and on the basis of CT data, we used to factorize how much it's a 40 केवी के फोटोन को अगर इतना अटेन्यूएट हुआ होगा तो 511 वाली कितनी हुई होगी. So on the basis of this, attenuation correction factor was generated and that applied during the collection of PET data. So in which I try to display how the PET CT was done. So you can see survey, this is spot images, then CT, and then if needed, then attenuation correction is generated. If needed, then you can do a contrast CT, and then you can fuse. Then subsequently, we used to fuse and generate the PET CT data like that. 10 millicurie was the standard dose. Now, with the high modality, used to around 5 to 6 millicurie. And after time is also right now reduced around 40 to 45 minutes. Throughout attenuation correction, we all are knowing that how CT image was formed on the basis of view map, hospital unit, and same information we utilize for a correction of PET photo. It cannot be same, so that's why a scaling factor, attenuation correction factor is generated. PET is different. PET is different because we are labeling the biomolecule. Biomolecule labeling give an opportunity to have a clear-cut information. And second is higher sensitivity, and we used to inject in very small molar quantity, nanomolar and picomolar. So that gives us to imaging the protein receptor hormone analysis. Nowadays, easily we can do the lesion correction. This is the FDG based. How it is different from glucose because there is no enzyme for FDG 6 phosphate. That's why it's trapped in cell, and we used to imagine on the basis of FDG. However, in glucose, it's processed and reached to the Krebs cycle or glycolysis. But FDG cannot reach for a glycolysis because it's a trap in glucose 6 phosphate phase. We have to know the chemistry also for understanding the nuclear medicine and biology. So variety of we all knowing that wide range of role of PET CT widely accepted in all variety of oncology cases, not only oncology cases, neurology cases too, and cardiology. These are some important that used for diagnosis of primary tumor, staging, monitoring, recurrent and metabolic disease, and related therapy planning. That is the latest introduction. Very few centers are doing radiotherapy planning, but this is also very promising for us. See, anatomical, functional, we could not able to where its signal is coming by seeing the PET images. But once it's huge, then easily anybody can radiation technology detect where is the lesion. So this is a power of PET. Here in assessment, pre-chemo, what is the status, see the lesion, and post-chemo, how easily anyway फायदा हो रहा है. So there is no need to very clearly it is displaying that reduce significantly. This chemotherapy is effective. If size was not reduced, then clinician have an option to change the chemotherapy drug. So that way, assessment of whether the chemotherapy is effective or not is easily possible. And PET CT is giving important, very important contribution. Same way here, insist after 2 weeks, see lots of improvement. Actually, almost no significant abnormal effect. With rapid response in CT pre and post, see how much very significantly improve RT planning. We can delineate volume very clearly. RT planning here we can reduce in that way unnecessary area, and that way reduce the radiation side effects on patients, and deliver maximum dose to the tumor, not to the normal, but radiation. Because the nuclear medicine technologists going to work, is working in nuclear medicine field, that isotope is unshielded and have high, very high radiation factor. Radiation wetting factor is very high. So we used to have a take a precaution. Precaution means you have to follow the radiation protection rule. Radiation protection rule is time distance shielding, and here one more is contamination. How to prevent contamination? Because fluorine 18 is a positron emitter. So first it emits beta positron. If you get contaminated, then beta plus means positron deliver complete dose in very short range. So that is going to much more harmful for us. So we used to be very cautious, should not get contaminated. Otherwise, if you take a proper time distance shielding, the way we used to work on where the shielding is required, then you have need to be stay for longer time. Then you have to work behind the shield, the movable shield or fixed shield. Like same way, you have to maintain a safe distance from patient, and you must ensure that patient should not get scared by maintaining a very large distance. So you have to maintain a distance. Every inch is significant while maintaining a safe distance and time. Whatever time is needed, just spend required desired time and move away from patient or a scanner room. So exposure is cyclotron is very high in cyclotron. If anything happens, then otherwise it's completely safe. Cyclotron like Linux. Radio pharmaceutical radiation, yeah, we used to take a radiation in radio pharmaceutical production where FDG synthesizes and other radio pharmaceutical synthesizes is happening. Dose dispensing time, yes, there is also significant radiation, and dose administration time because the finger dose will be very high, and during patient handling and while doing a CT from exposed. So, radiation safety protocol should be very well established in any facility that will reduce the significant radiation exposure, and that what we need a proper training and proper shielding ability, best radioactive waste handling procedure, and SOP, how to dose dispense, how to decontaminate, how to maintain a safety, should not be get decontaminated. You have to follow the radiation safety protocol strictly. Exposure to a staff of patient, yes, significantly high, but we have to reduce significantly if we follow the time distance shielding and reduce it. But PET CT, major dose patient used to receive because of CT. The CT 7, so 13 to 15, or you can say higher. Millicurie single scan patient used to receive because of whole body CT. So that is a significantly that PET CT should not be get repeated frequently in short interval of time. Yes, patient treatment and patient diagnosis is important, but it should be justified because doing a frequent PET CT give a significantly higher radiation exposure to the patient. So we are now I'm moving to towards the end. So digital PET CT is a new introduction. I told you in my previous slide that earlier this BMT was that much higher. Now I see the small cheap size of detector, that is one by one coupling going to give a very sharp spatial resolution, clear-cut picture, and much more sensitive system. Now introduced with the digitization of silicon photodiode digital detector, introduced by all three companies, G, Philips, Siemens, and also Canon recently, and Toshiba too, and one News of also. So, very significant way, all company is now digitized PET system. So future PET city will be going to be very sensitive and going to produce very good quality of image, made possible to reach to the 2 mm resolution. 2 mm resolution is still not possible in PET image. Still, we are getting the 4 to 4.5 or 5 mm resolution in PET images. How see small. This is a G technology. Light plus digital detector. Conventional is so long. This much. 10 to 15 centimeter long. This is an integrated chip, small light plus digital detector introduced by G in 2018. That I'd like to show you now phantom study. See how in digital detector image clarity how it is improved if you compare with conventional. And if you compare with CT, then still very poor. So that's why CT specific resolution is very high. That's why we want to have a CT with PET. Although we are improving, but still not comparable with the CT. Now, because of radiation burden and the challenges with soft tissue, that soft tissue resolution was very poor in anatomical in CT. Researcher realized that why not we should have a MR PET result. And what was the reason behind that? Basically, because anatomical image quality in MR is much better than PET, much better than CT in MR, excellent spatial resolution than CT, especially if you think about the soft tissue and clinical penetration of MR in anatomical imaging is significantly higher than CT. Where is MR is lacking in poor in sensitivity, and in that point sensitivity PET is excellent. Molecular imaging limited, here is the wide range excellent. So why should not have best integration, best hybrid technology, and that give us a platform for our researcher to have a MR PET. And nowadays, few center, one center in Delhi and one center in France. I think 2 or 3 centers in India having a PET MR system. One in government, one in private, maybe more in private, but government one in France. So, and these are all development happen because in MR, PM tube based imaging detector system was not possible because at alter because of magnetic sensitivity of complementary to alter the gain of PM tube. So uniformity of system get deteriorated immediately. So that's why silicon, after the introduction of successful silicon photo multiplied to an avalanche photodiode, it is possible to integrate MR PET in one gantry. So initially, researchers were thought to have a separate image fusion and require and data transmitted to the some few meters away, and where MR and PET in data integration will be done. But after the introduction of silicon photomultiplied to FPD technology, it was first introduced by Philips Siemens FPD technology or their PET MR, and subsequently Philips introduced first time silicon photomultiplier 2 and GLC. Now all three companies have a silicon photomultiplier 2 based crystal detector system for PET CT and PET MRI. See, this is the PET MRI cross section. Here is the RF coil, and above the RF coil is PET CT detector, and see the placement of all radiant coil, primary magnetic coil, magnet shielding coil. It's like the MMR. So clinical potential is now going to have a much higher than what we I have discussed in PET CT. So the new insight in the field of neuroscience and neurological disorder that was not possible in anatomical imaging of neurons by using a CT. So this will open the new field, neuroscience and neurological disorder. That is also main application of PET MRI. Although PET MRI is also highly applicable and good for clinical diagnosis, oncology, and cardiology purposes. But initially, it was developed keeping in view of neuroscience, technology, and neurological disorder management. That's why more possible for brain scanning, brain function, metabolism, oxygen consumption, and perfusion. Oncology also very useful for identifying. That will also what advantage of PET MR is that MR, because of MR we are using a magnetic properties. We reduce significantly the CT component of those and get a better image quality, anatomical better image quality. So both way advantage. We now will have a better soft image quality of soft tissue, better image clarity, and significantly almost 60 to 70% we reduce the radiation dose in PET MR. The advantage first and the most important is the radiation exposure. 60 to 70%. You'll get a much higher soft tissue contrast. MRI law additional technique, possible angiography, functional MRI, diffusion, spectroscopy, perfusion imaging in one signal. Although there is a challenge that I will discuss. See how clear PET CT, PET MR, clear, very clear, nice anatomy. We all are knowing that MR images how clear depicting the soft tissue formation. So possible geometry, when researcher think how it should be done. The axial object separate MR scanner and PET scanner. That model was accepted by Philips. Hybrid, that model was accepted by first and introduced by Siemens. And PET insert. Can insert in MR scanner. This is Japanese, that was not available commercially. This is a Philips PET MR system. Time of flight is a new technology. The basis of decay time system used to register the event. And the time of flight machine is very fast in data acquisition. Now, right now we have, that is not a true time of flight, but yes, we have a good Philips having the 6 people nowadays reduced to 529 people second. We are using LYSO crystal. The time of flight. So जितना सिस्टम का टाइम ऑफ फ्लाइट रेजोल्यूशन फास्ट होगा उतना वो क्लियर आइडेंटिफाई करेगा कि सिग्नल कहाँ से आ रहा है. जितना हम कम आइडेंटिफाई करेंगे उतना दूर में बताएगा कि सिग्नल 10 सेंटीमीटर के बीच से आया है या 25 सेंटीमीटर. देन यू हैव टू डू अ प्रोसेसिंग ऑफ दैट 10 centimeter area. But if true flight possible means reduced to the 100 picosecond time of flight, then it will be system will need no processing of PET data. It directly acquire and you can see the PET images because so fast time of flight acquisition doesn't need to process the data. It generate images. Directly it will be generated. It's not possible now, might be going to happen in future. So time of flight technology, density gain is very high for in large patient. It's very good for large patient. So apart from so many advantages and the power of PET city, there is also certain limitation. Still, we are fighting with this uh, initial limitation of fusion of incompatible modalities. We cannot use ultrasound and CT images. For that, we need to have a software based. Second is by hybrid modality throughput abilities. If you will have a stand modality of CT, you can do a 120 patient cases in 12-hour or 13-hour shift. And in hybrid, we cannot do 10 more than 15 or 20 cases of PET CT. Because of integration and so much software information, radio chemistry, data acquisition, different modality fusion, we should have a highly skilled manpower. Right? That is the opening scope for recent technologies. We want to grow further, then you gain a highly skillful knowledge and will be satisfied with your higher remuneration and position. Also, input cost is high. In installation of PET city, it's significantly required twice on price than a city system. Challenging integration and workflow that is very much challenging for a PET city. Still, PET city workflow means application software is still not completely developed. That in which type of disease, which workflow should be done, which acquisition protocol should be done. These are challenges. Still, if you want to grow as a like a nuclear medicine cases, then you have to have a very good innovative approach. Like if you want to grow for individual nuclear medicine procedure safety to higher range, then you have to understand the radiobiology and immunity. Some person wants to grow like a radionuclide counting accuracy medicine system, then you have to understand the better radionuclide therapy because nowadays personalized the era of personalized medicine. So everybody wants to give a higher and good therapeutic, appropriate therapy dose for individual patient. For that, we need to have a radionuclide therapy procedure, understanding very smart, clearly. Understanding the image formation process, because that is also a now new opening for who should have a software interest in software side. Generating and developing a software is also a very good opportunity. We all are knowing our few colleagues are working as application specialists in different manufacturer or firm that they are producing a different equipment. Also, the various very good integration with physiologists, internal medicine, especially radiopharmaceutical scientists. So, I'd like to say you this is the opening of nuclear medicine. A scope is very wide. If you want to grow as a radiochemist, you have a scope. You want to grow as a MR spectroscopy, you should have a very good scope. Nuclear medicine production, radiobiology, radiation physics, medicine, integration with anatomy, receptor interaction, nanotechnology, dosimetry, metabolic image processing. So very wide range of scope, but we have to ready to transform yourself. You have to change. You have to accept that I want to learn more, and in such a way that you should able to practice. You should able to practice this field. That only possible. The scope is enormous. And if anybody wants to pursue higher career in fusion imaging, That will be very good for financially satisfaction level will be high, and position is the widely accepted in research sector, in the production sector, in the diagnostic center, R&D institution, everywhere possible. So this is a future of imaging technology, whole body PET CT. This is very high sensitivity, having high sensitivity, 10 times minimum. Radiation dose is only 30 times minimum. In 1 millicurie, instead of 10 millicurie, 1 millicurie and half millicurie, 0.5 millicurie, imaging is possible. See, and you can do a whole body imaging in only less than a minute, 29-second images. See how depict clearly. So that is opening a drug discovery. We can directly trial on patient. How it is doing, how the pharmacokinetics, excreted dose distribution, how is the distributing, where it's going, how much is going. So it will faster the drug discovery process. And with this, I'm closing this my talk and see this video. Hopefully, you will enjoy it.
Frankly, it was a measure of ridicule, actually, back in the field, because it was just considered too grandiose. The scanner is now completed, and we recently acquired the very first human images. It was an amazing moment. We found more detail in images than we've ever seen before. If we want to get the same quality of images that we get today, we can do that in minutes or less.
So less than 1 minute, half second, 30-second image is possible.
More quickly.
See how technology is going to transform us.
To a return flight from the West Coast to London. We think that's going to greatly open up the application.
Image Explorer. Thank you.